go ahead and get started for those of you that are on. So the way this is just going to work today is we don't have a long time together, but what we're going to do is just introduce our panelists today and then go over a couple housekeeping items and then jump into actually a little bit of a Q&A with our panelists about some of the strategies that they're doing or some of the best practices they've been doing or seen as far as, really utilizing and embracing advanced practice providers. So thinking about more so your nurse practitioners and physician assistants. And then we're going to try to leave 10 to 15 minutes at the end for Q&A. I know we've already got a couple of people that have emailed some questions. So we'll try to make sure to have some time for a live Q&A at the end. With that, let's go ahead and get started. So my name is Elizabeth DuBois. I'm a doctorally prepared family nurse practitioner by training, and I've been practicing now for probably about 20 plus years, mainly in primary care, but also some emergency department and urgent care. I am a principal with COPC Health Solutions and am overseeing all of our APP workforce programs that we have here. Let me go ahead and introduce our panelists today. I'm really excited to have these two individuals join me. I've had the pleasure of working with them the last couple of years, and really just excellent leaders in healthcare, leaders in the APP world, leaders in general and value-based care, really changing the landscape and pioneering some great pathways for the rest of us. So first we have Beverly. Beverly is also a doctorally prepared NP. She is currently the vice president at Summit Health, which is a large healthcare facility in the New Jersey, New York area, and they are under the umbrella of Village MD, which is obviously all over the nation. And then the other panelist, and I'll give it to her in just a second, we have today is Helen. Helen is the Director of Advanced Practice Providers for COPC, or Central Ohio Primary Care, one of the largest physician-owned primary care facilities in the country, primarily based in Ohio, with I believe a little over 80 clinics. She probably can correct me on the number there. So let me go ahead and let Beverly and Helen just give a little bit more about their background.
Thank you.
Beverly?
Thank you. We're so thrilled to be here today. Looking forward to our discussion. So as Elizabeth said, I'm a doctorally prepared advanced practice nurse in New Jersey. I worked in internal medicine for 4 years. Most of my background in nursing has been in acute care setting, hospitals. For the past 10 years, I've been working in the magnet recognition world. I'm not sure if you're familiar with that, but advancing registered nurses and also advanced practice nurses on the journey of excellence to become magnet designated facilities. I came to Summit Health 2 years ago to basically work on our primary care fellowship program. And when we got here, we realized there was no opportunities for professional development, which we'll talk a little bit about later, but really excited to be here with you. And I'll turn it over to Helen.
I am Helen Leahy. I am the Director of Advanced Practice Providers. I'm an adult gero and acute care trained nurse practitioner. I started out most of my NP career in the hospital with a hospitalist group, and then have moved into some of the primary care and kind of oversee all of that, inpatient and outpatient, for our group. I've been with COPC for 15 years. We've developed and grown a ton, and I'm excited at how much we now are working to really grow our APP culture and our APP numbers. So it's been very exciting in both the inpatient and outpatient perspective.
Thank you. And I think what you'll notice with both of these panelists is they just have extensive experience working with maximizing the utilization of APPs, and have had to overcome a lot of the hurdles that I think probably a lot of us here have seen within our organizations, and sometimes the barriers we have and how best to utilize NPs and PAs. And so excited to pick their brain a little bit and hopefully share some best practices with you guys here on the phone call or here in the webinar. Let me just go over a couple housekeeping tips. So if you have any questions throughout the session, you can submit them through the Q&A feature, which is new to me, but in Teams, right up at the top, you can see a screenshot there. You should see a Q&A little picture and button on the top of your screen. So you can submit them there. You can also email them directly to info@copehealthsolutions.com. You can put them in the chat box if you want. We'll do however we can, whatever which way we can to find your question or answer your question. And like I said, we'll try to give some time at the end for that. You'll also receive a copy of this presentation and a link to the recording. If you registered for this webinar, we can send all of that over to you and written Q&As as well. After the presentation, we'll send you out a brief survey. If you could give us your feedback and response, we're trying to continually put out educational sessions like this for the community, and really helps us to know what you guys are looking for or what helps you guys best as well. Okay, with that, let's get started. So let me go ahead and great. Well, let me first ask just both of you. I mean, you both work at pretty large healthcare facilities right now, who, are very much embracing value-based care and really, kind of setting the stage and moving forward in the value-based care arena, with rapidly expanding primary care access that we're seeing at both your facilities. What are some of the major changes that you're starting to see within the workforce as you guys do that, or as your organization does that, or, just responding to what's been going on externally? What are some of the big changes that you're starting to see within your workforce? Let me go ahead and Beverly, shoot it to you first.
Sure, of course. Well, here, I just want to also clarify that my focus is in New Jersey, kind of the middle and the northern part of New Jersey. And when, we first started, we weren't hiring any newly licensed advanced practice provider. There was no infrastructure to support them. So on this trajectory of bringing a fellowship into the organization was a big change for the organization, because the mindset was that we're not taking newly licensed individuals. And it was really a lot of level setting, explaining the role, and having them understand how long it takes to get individuals up into being capable and comfortable with managing these very sick individuals coming into primary care. So, taking a look of the workforce, the nurse practitioner and the physician assistant's role have been around since 1965, and realizing that the training of these professionals is not going to change. That's one of the arguments of American Medical Association. You'll never have them train with 4,000 hours, but the part of this is getting people comfortable with, we do have a responsibility not only to our providers that are coming in, to our patients and to others, to develop infrastructure in order to support, so that we can manage burnout and manage individuals so that they're comfortable in caring for patients in primary care.
Yeah, I think that's such a good point. And Helen, maybe you can expand on this a little bit. I feel like so many of the organizations, and maybe some of the organizations you guys are with right now, what you'll hear is, yeah, we may want to utilize APPs, but we really want them when they're experienced. No one wants to touch these new grads. And how are we going to really build up the workforce without that? Maybe Helen, you can also talk a little bit more about that.
Yeah. So one, I think we've really tried to talk about the assumptions people make and get past some of those. We get a lot of, oh, my patients won't want to see, oh, my patients won't do that, they're not trained adequately, and just really getting past some of that. But also saying things like, well, they might not be fully experienced, but with some training on your part, you can really start that collaboration and make it the training that you want and that you can help guide. And then working to try to standardize some of that too, and make sure that we invest in that and work towards that. In our organization, we do have a lot of retirements. and changing the messaging in general, right? It's just a known fact. There aren't enough providers going into primary care, and there are plenty retiring. So I think we're trying to also work on hey, we have to have an ability to really help our patients. And in the value-based care space, we're really turning away from that fee-for-service into that bubble wrapping and making sure that patients are getting what they need. And who better to do that than APPs, right? Because they are already doing a lot of that quality time, education, preventative care that really, really is needed when you're trying to think about value-based care rather than fee-for-service.
Yeah. And so, I mean, as you think about, a lot of times this is where APPs spend a lot of their education or their schooling is around doing that kind of chronic care management or the preventative visits. I think I know with NP, we've seen huge growth in the numbers and the schools that are opening to graduate NPs. We've seen it the last few years with PAs as well. I think U.S. News and World Report said it's the fastest growing profession last year, and they're expecting a 45% growth in NPs the next 8 years. And I think as quick as schools can open PA and NP programs, they're doing so. Helen, what do you expect the primary care landscape to look like with the change? If you do start seeing this increase in utilization of APPs, do you expect the primary care landscape to stay the same, or do you think we're going to see a lot of changes there?
I think we're going to see a ton of changes in the next 5 to 10 years. I think it's going to be significant, both out of necessity, but also out of awareness and people wanting and asking for that extra care. And it's hard, right? This is a lot to be able to do that, but accessibility and resources available to our patients for care is one of our major issues in primary care. And we don't want patients going to the ED, going to urgent care instead of coming to their PCP and being able to help get that care that they need. We have not only a crisis in primary care, but also overutilization of some of those resources that don't need to be utilized. So it's really no longer a debate of whether or not APPs are in primary care, but now a discussion of how many, where, and how to properly implement and utilize them.
Yeah, that's great.
I'm sorry, there's just one other thing that I wanted to add as well. I mean, one of the things that we found also is, through COVID, not only was the APPs, the nurse practitioners, physician assistants training effective, but also our physician colleagues, where they didn't, they were pulled from their primary family practice rotations to be in acute care to help the healthcare system that they were working with at the time to be able to care for the COVID patients. So then when they came out of residency, they also needed additional support when they came into practice. So that's a huge component of this as well. And organizations not only having support for new APPs, but also new physicians coming into practice.
Yeah, it's a great point. I think, as we've been doing a lot of interviews lately, I keep hearing, how varied the clinical experience and clinical rotations have been for individuals that were in school during COVID. And, so many individuals had to use simulation and telehealth. And so, a lot of individuals are going to need an investment in their training and education across the board. And I think, to your point, Beverly, we have to not only think about APPs, but we have to think about our physicians, our nurses, everyone, and what kind of transition to practice they're going to need as they're getting into the real world, let's say. I guess to that point, let me ask you, Beverly, a little bit of a follow-up. So, we know we need to utilize more APPs. If, let's say, I'm at an organization that has traditionally said, like, no new hires, but we're not able to get enough experienced APPs. And so we have these significant provider shortages. What are some of the things we could do as an organization to start preparing, or, what are some of the things you might want to talk to leadership about to start thinking about as they potentially explore, embracing an increase in utilization of APPs?
I mean, it all goes back to the realization that the workforce is changing moving forward. You know, less and less physicians are going into primary care, more advanced practice providers are going to be in that realm. And it's almost coming to a crossroads where organizations need to embrace this change in the workforce. And it is an investment initially, but a long-term investment for the organization to be able to provide so that they are able to attract individuals to come. Just being honest, in our organization, we did see our individuals who were applying for positions decrease. You know, if you have experienced individuals in your market who aren't flocking to your organization, then you're really going to be in trouble, because if you're looking at patient access and getting people into your system, you need someone to be able to evaluate them. So you're going to have to make some very difficult decisions if you can't, you know, if you don't have appointments in order to see individuals. So it really is strategic planning, looking at the market that you're in, and really talking to your executive team about this is the direction in which we need to go.
Yeah, exactly.
To add to that, I would say, you know, we're a heavily flooded market here in Columbus with different health systems. And one thing I often say to our leadership team is, well, if they're not going to get the care here, they'll just drive down the street and head there where they will see an APP, and we won't have any access or ability to care for that patient in the way we want to.
Yeah.
And that also goes back to, you know, the contracts you have for value-based care. You know, if you're looking at managing, you know, X number of patients, if you don't have access for them, they're going to be going to the emergency department, which is going to raise the cost of care, which is going to affect your organization. So it's, you know, where do you spend your reimbursement dollars better in training the people, keeping your individuals within your own organization, or, as you said, Helen, having them go down the road to be cared for in an emergency department or some other organization. We also have very many hospital systems around our practices as well.
I really like that point you just said, both of you. I mean, I think, you know, when you think about it, just embracing value-based care should actually also make you a better retention place, you know, as far as the workforce. And, you know, if we're thinking about really caring for our patients and keeping them out of the hospital and, you know, preventing the exasperation of diseases, you know, we're investing in our workforce, and we're making sure that our workforce is prepared to take care of these patients. And, you know, I think, as most of us can attest to, when we're looking for a job, has a brand new APP or maybe even a few years out, you're looking for organizations that are going to invest in your education. And you're not just, you know, similar how you don't want to be a patient on the mill, you're not just a provider, you know, on a treadmill, that it doesn't matter who you are or how many patients you see or the quality of care you give. And so I think when you talk about the value-based care, you're also really bringing it back to the retention of your providers and investing in your workforce.
And, you know, the other piece of this as well is that as you mentioned, Elizabeth, is investing in your workforce, because, you know, our advanced practice nurses, nurse practitioners, and physician's assistants are a little bit more mobile, typically, if you think of the population versus physicians. You know, so physicians come and settle, they get their panel of patients, they typically stay, instead of the mobility. So if you know, plus we're also we're going to be having Gen Zs, so, you know, we have millennials, and it's a different workforce. And if you don't have a strategy in order to retain them, you know, if you have them come in, you're not supporting them through that as they transition. If you're not supporting them, then they'll stay until they get some experience, and they're going to go somewhere else. So you really have to make a concerted effort to say, this is what we want, and this is what we need to do in order to get there.
Yeah, there's plenty of jobs out there for PAs and NPs. You know, there's plenty of very nice remote cushion jobs for NPs and PAs. So you have to definitely be thinking about that. Helen, let me ask you a question. We get a lot of times from organizations, you know, that we'll start working with, that are thinking about how they utilize APPs and how they maximize the utilization or optimize the utilization. And one of the questions we initially hear a lot is, well, what is the right ratio of physicians to APPs, and how do I figure out how many NPs or PAs I should have for each one of my physicians? How has your organization approached that?
We, in all honesty, have struggled with that as well. And I get asked that frequently by our providers. There's variability to it, of course. And when you get into that value-based care rather than the fee-for-service emphasis, it really is dependent a little on how many high-risk patients you have and how much how many of the panel you are at risk for, right? But APPs have been doing value-based care for years, right? Without even recognizing or knowing that. We've been doing I'm going to take the extra time, educate you, talk to you about this. We do a lot of those things that aren't billable, and just haven't been recognized. It's always hard. I say to everybody, it's hard to identify the amount of money I saved because it wasn't spent, right?
Yeah.
And it's a longer term, it's not an immediate. So it's at the end of the year when you see how that patient that normally costs you a higher PMPM per member per month, that now costs less, you can see those moments. But I think that the general representation has been that an APP and a physician can share a panel of 2,000. I would argue that if you're dealing with a lot of high-risk patients or a lot of patients you're at risk with, it probably should be less than that, somewhere around the 1,500 if you're doing it right and you're seeing them 4 times a year, 6 times a year, seeing them to prevent them going from into the hospital, trying to get those immediate hospital follow-ups if they do go into the hospital. So 1,500 is usually, but I try really hard to be vague because I think that there is some variability in where you're practicing and what your panel looks like.
I think that's a really good point. And also, your end goal doesn't have to be done in the first year, that this
Right.
can be fluid. And so, maybe if you're an organization that doesn't utilize APPs at all, think about, how many do you want to bring on initially that first year? Maybe it's a handful, maybe it's, the first 10, and making sure that you have a structure. To Beverly's earlier point, you have an infrastructure set up that's really going to start, these APPs on the right track and build them. And as you, get that infrastructure in place, you can then start thinking, okay, can we bring on more? What is the right ratio we want to have here? Let's start looking at how many high-risk patients we have. I think that's a really good point you raise, that there may not be like one simple formula fits all, but this is more fluid in trying to think about, where you want to get and maybe the different steps you take to get there. Beverly, I think you. Oh, sorry.
Go ahead, Beverly. Go
Yeah,
ahead.
no, I just had a couple more comments. A couple of things, depending on where you are, make sure you take a look at your state regs, because typically more for PAs than nurse practitioners. But there are rules about how many PAs can be with physicians and also APNs. So you definitely want to make sure what your state regs state. And one thing I've learned being here, there is not one rule to fit all. There is absolutely not. It's being flexible, it's being patient, it's creating relationships over time, which is very, very important. And the other thing to consider too, particularly for our nurse practitioner side of things, are you in a fully autonomous state? Are you in a restricted practice state? Because so in New Jersey, we are, we have to have collaborative agreements and delegation agreements. And part of that is the physician has to sign off on so many charts in a certain period of time. I'm not going to get into the specifics of it. But once again, when you're looking at those ratios, you also have to look at the burden of the collaborating or the delegating physician. How many charts do they have to review? So that has to be discussed and thought out of it as well. So it's not a one ratio fits all scenario.
Yeah, and to add to that, for any of you guys that have had to look at the state regs and try to figure out exactly what this means or that means, you probably know it can be pretty difficult. And so I'll give a shout out to, you have for both the PA and NP, you have national organizations, and you have chapters on top of your, state regulations. And so I know for me throughout my career, they've been great people to reach out and say like, hey, I'm not quite sure I understand the New York law that just came out with this. Can you tell me exactly what this means? Or can you jump on a phone call with me? There's the American Association of Nurse Practitioners, there's the ANCC, there's the ANA. I think the AANP does a really good job as far as specific to, sometimes the NP regulations. And remember, not only for your national organizations, you have a state chapter, and then you have your local chapters. And so if you're trying to read through the rules and try to figure out exactly what this means for you, feel free, obviously, to reach out to us and we can help guide you to the right people, but also look at your state and national organizations that help you with this kind of stuff. And I find being members of them so that you can ask questions freely is very helpful as you're starting to think about your practices. Helen, did you have anything more to say that I cut you off with?
I was just going to say, what Beverly was saying, formulas are great. They do help physicians to understand numbers and to help them see how they can improve things. But they're not everything. But one way that we've really found to be effective is to just literally use accessibility and number of appointments, right? So if you have a high risk patient and we're saying they need to be seen on average probably 6 times, an annual a follow-up and then some high risk avoidance things, then you have to calculate that into how many appointments you need to have and do you have that availability? Like it's just a flat numbers game then to be able to say like you can't possibly see that many people. There's not enough hours in the day. So you're going to need help in some capacity. And how does that work?
Yeah. Great point. And that leads me to a couple more questions for both of you. We've continued to see a culture shift with the utilization of APPs. And I think to what both of you have said, this has somewhat been forced a little bit by the hand maybe, and needing to create more access and really think about our workforce here. But a lot of challenges can come with a culture shift, with a culture change, with, a new workforce model, a new infrastructure. And so, some of the challenges I think I've seen within organizations before is just, what is the physician buy-in for the utilization of APP? What is the relationship with the physicians? How do we market APPs? How do we market them to not only the patients to understand who they're seeing? A patient doesn't want to feel like they're being given like some secondhand provider that may not know as much on how to take care of them. How do we help the staff know what it means to see an APP? Because the other thing I've seen is, maybe the front desk picks up the phone call and says, well, I can schedule you with Dr. So-and-so. It's going to take 2 months, but I can give you this, PA that could see you tomorrow. They're a physician assistant. I'm not sure, they're not the doctor, but I could schedule you with them. And so you think about the cultural shift or changes within the staff too. Beverly, maybe you could speak a little bit as your organization is increasing the utilization of the APPs, how you guys have handled some of those barriers or challenges that you might have encountered with the utilization.
Yeah, no, absolutely. I mean, one of the things that's important is to explain, and you can't just do it once, but to understand what the scope of practice is for physician assistants, advanced practice nurses, and primary care, and what they can do. Mostly, they can do everything in primary care. When you get into specialties, there's a little bit more nuanced, but in primary care, it's extremely important to talk to the clinical teams on the unit, and it can't be done by one person. I firmly believe that the individual advanced practice provider themselves needs to advocate for themselves. This is what I can do. Let me explain my role. This is my scope of practice. This is what I taking care of. We've done some scripting. We have a call center. We've done some scripting for them. We've done some scripting for our patient service representatives that are taking the calls. But the more education that you can do about the role of the advanced practice nurse, nurse practitioner, physician assistant within primary care. It's extremely important. Marketing is definitely an important aspect of it. The one thing that's important as well, and I wanted to mention this when you talk about working in primary care, is try to stay away from incident to billing. This is just my own personal. There are strict rules and regulations, but you don't want to optimize and say, well, this is why we have advanced practice providers, so we can use incident to billing, because this is going to restrict their practice. This is not going to get you to someone who's able to see this complex patient when they come into the organization. So I just wanted to make sure that I got that in there. But we've done a lot of work along those lines, and it is, so there are some patients who will come out and say, I want to see a physician, and that's their right. But what we found more often is once they have that initial visit with a physician assistant, a nurse practitioner, and then they're like, oh, okay, this is my experience, and I had a really great experience. Can I make my follow-up appointment with you?
Mm-hmm.
So, Helen, I'll turn it over to you.
I mean, great points, multiple great points in that. Thank you for highlighting the incident to billing. That question comes up a lot amongst organizations across the country. How do we maximize our incident to billing? If you are looking into that, highly suggest that you look at some of the articles that President Stephen Ferreira from the AANP has discussed about this topic. The CMS has actually recommended, CMS has actually recommended to go ahead and move away from this. It just hasn't officially passed yet. And so, be very cautious if you're spending a lot of time reconfiguring workflows to try to maximize incident to billing, because to Beverly's point, I think you're really missing out the maximizing the actual utilization of APPs. I think there's a good chance this won't exist, much longer. And I think if you really look at the value-based care model and you're thinking about that and how to optimize that, we're talking about way more dollars than we are with a few incident to bill dollars here and there. So thank you for bringing up that point. I also I just want to highlight it if you didn't hear it, scripting. And so she mentioned they have scripts. They have scripts for, you got to think about your front desk staff, scripts for your MAs, scripts for how your APPs introduce themselves.
Mm-hmm.
How do they say, this is my background? How do they, introduce themselves to a patient? How do they introduce themselves to the physician? Scripts for the physicians. How do they talk about their colleagues? I think it was at both your organizations where this topic came up, and, we wanted to try to make sure they understood too. And so it's not a one time, everyone's done, we've heard about it. It's a continuous, education and explaining the scopes and the practice. But then I really love the idea of having scripts for people to help them feel more familiar with that. Helen, I wanted to ask you something about this too. Beverly was talking about really maximizing your utilization of APPs and not getting stuck up with some of this like incident too. I get asked a lot. I hear different organizations do it different ways. We put all of our APPs in the same day center. We have them doing just the acute visits. Or some organizations, we have our APPs only doing, the preventative, and maybe even following the incident to bill model where, the physician has seen the patient, set up the care plan, and then the APP is just going to do the follow-up. When you think about, where to put the APPs best in your organization, how do you factor in, do I put them in just same day? Do I put them in just preventative, or do I have them have their own panel or share? How do you think about that? And what do you think some maybe best practices are as people are thinking about that?
Yeah, so great question, and one that I work a lot with our own physicians on about how to best utilize. We have actually come up with a formula for our fellows where we're saying, here's what we recommend. And it has percentages, right? 20% should be acute, percentage that should be wellness, percentage that should be high risk follow-up, percentage that should be chronic disease follow-up. I think there's utilization for all aspects, and that we can't grow and develop and learn unless we're able to care for the patient in totality, right? So 100% getting away from that incident two and stop thinking about that. And instead, what does the patient need? What access do they need for us? Also, none of us got in to just do one thing, right? Like I don't want to do wellness exams for the rest of my life. Like I want to also be able to help take care of that patient that I saw for a wellness last month because they're having an issue of what we talked about. So making sure that you get that follow-up and that continuity of care and build that relationship. We do have a same-day center. It's not a walk-in, but it's by schedule and essentially acute visits for people. We also have offices that have sick bay time, so from 8 to 9, they can walk in and be seen. And the NPs do run that from like an 8 to 9 period. But the big fear was, what if 100 people show up? Well, good news, all of their docs help if that's happening. Everybody takes one. It builds a team. It also is then everybody kind of sees those acute patients, and then I get to transition into seeing some well visits. So I'm a firm believer in making sure that there's a good mix. Now, if you're really great at treating CHF patients, and maybe you should be the person who sees that, again, personalizing that, but making sure we're making it more about the patient and getting them in to be seen, rather than I want to be able to incident to bill this, right?
Definitely.
I definitely discourage, and I always start with, please don't have your APP just see every acute visit. Like that's not what we need. We need everybody to understand how we care for the whole patient.
I think it was a good point you brought up too. Like, it's actually not what most of us want to do. So if
No.
you're thinking about retention of providers, I don't think the physicians want to be stuck in just seeing the well visits all day. I don't think the ABPs want to be stuck in just not, and I don't mean stuck in a bad way, but
Right.
I mean it in that, like, we all want to, the reason we got into primary care and family medicine is because we want to take care of the patient and the entirety of the patient. That's I think a beautiful thing that we get to do in our jobs, where we get to help them if they're not well, and we get to, try to prevent them from becoming sick. And, that's really a good aspect to retaining your provider too. Beverly or Helen, you mentioned fellowship. So let's talk about fellowships a little bit, because that connects the three of us. So both your organizations have APP fellowships. And you're both, this is not your first cohort. Beverly's cohort actually just graduated yesterday, her first cohort. And they're in their second cohort right now, going to be starting applications, I think, for the third cohort soon. And Helen is, her organization is interviewing right now for their third cohort. So you both have fellowships. Maybe you could tell me a little bit about, why did you want to start a fellowship? What made you kind of move towards, hey, this is something we want to go ahead and embrace, and why you didn't think you could just do like a typical onboarding and just start bringing on more APPs?
So a couple of great reasons. One, we need some standardization. We need some extra development that is specific to primary care, right? We've all been in school, we get some of that, but we don't get enough of what we end up going into. And we need a little bit of specialized training in that to begin with. Second, I really wanted the organization as a whole to recognize that this is important. It's not just to throw somebody to the wolves, have them go see a bunch of patients and they'll figure it out. We hit a lot of barriers of, I don't have the time or the money to educate people. I need them to already be functioning. So this is a great way to be able to say, like, we'll help, right? With COP's help and our team, we're able to say, like, here's where we're gonna help get you up to speed. And the doc doesn't even have to worry about that, really. Like, they can they are a part of the process and we want them a part of the process. I actually love having them be the preceptor and we all form the relationship. But it's a great way to say they will be up and ready for you. And here's your expectations that are very clear so that you're not having this expectation and they have a different one, but mostly for consistency and standardization. Like I just really wanted some very clear lines.
Because it's pretty varied in school, you know, and not even school to school, but student to student, especially as we were speaking about earlier with COVID and the clinical rotations so drastically different than even when we went to school. You know, you really have to think about how are you going to best prepare your APPs for your population. Beverly, you want to add anything on why you guys went to Let's Start a Fellowship?
You know, once again, you know, the surrounding areas that we were, the pool of experienced applicants were kind of drying up, and we weren't on interview, we weren't finding the candidates that we thought would be a good fix, and there was no bandwidth internally in order to have someone come in, and there is just no way you can have someone come in for 3 weeks right out of school and like poof, you're ready. So, and then just to, you know, reiterate to Helen's point, you know, with the standardization, and then also, you know, having this robust program that it not only benefits the advanced practice provider who's coming out of school, but I truly believe it benefits the organization. Because the support that you get within, you know, your primary care rotations, your specialty rotations, these primary care fellows are building relationships with specialty providers. They're getting advanced training in that specialty so that so they can better manage the patients in primary care. And, you know, it's interesting when we first started, you know, sharing what the fellowship would be in the organization. I mean, pretty much every advanced practice provider that I met are like, oh, I wish I would have had this. You know, everyone recalls their horror stories of when they first came into practice and they were onboarded, and then poof, they saw we're seeing 20 patients a day. And that first year in practice of just the trauma that occurred. So that was part of the reason as well.
Yeah. And I think with, you know, both your organizations, what's great to see is the value-based care component. And so as most of you guys know, you know, across the board, we don't get a lot of VBC training in academia. No matter whether you're a nurse, a doctor, a PA, you know, you don't get a lot right now. And some of us are in soapboxes championing across as many universities as we can right now to get this in. But, you know, until then, this is a great way to really think about how you're training your workforce at the very beginning of their, you know, job, their career, and what it means, what value-based care means, and how to take care of the patient. You know, and so both parts of both organizations, a huge part of the fellowship is the VBC component, which I think is really beneficial to the organization as a whole, which is a good thing to say. And both of your organizations are doing the 12-month primary care fellowship. And I think another benefit to highlight, if you are, to Beverly's point, you know, at all struggling in any kind of recruitment, a fellowship can be really good because most individuals graduating in P and PA schools right now want to work at organizations that are going to support them in their transition to practice. I think the latest stats are 80 to 90% of NPs and PAs look for these in organizations when they come out to have some sort of residency or fellowship, because they don't, you know, want to be thrown into the, you know, what Beverly was saying about the horror stories that we all share, you know, and that's not what we need to do to keep them in primary care. And so this can really help your recruitment as an organization in putting these programs in place and letting the incoming NPs and PAs know that you're investing in them. I have a lot more to ask, but I also know that we've got about 12 minutes and we already have 4 questions. So let me pivot a little bit so I don't forget anybody's question here. So we have someone that submitted a question early on, and that was, what type of specific professional development do you have for your APPs in your system? Beverly, do you want to take a shot at answering that one?
Yes, absolutely. I can speak to that. Well, when we started, the only thing that was available was the link in the electronic health record to up to date. And we
At least you had that. That's a step.
Yes, yes. But there was really nothing that was internal in order to do that. And the reality is, I mean, you really want, if you're talking about retention, you really want to have some things available for your workforce so that, they're seeing patients all week, and then on the weekends they have to go and do their continuing medical education. So we partnered with a local school to be able to offer continuing education credits for our APNs. Not that we were excluding our physician assistant colleagues, but we just didn't have a mechanism to offer CME Category 1 credits. But through our one of our local organizations, they reaccredited. So I'm happy to say that we're now able to offer it both. So we started out with lunch and learns. So what we did is we had advanced practice nurses and physician assistants. We did a learning needs assessment for our APNs and our PAs. We said, what are you interested in learning about? And from the learning needs assessment, we then reached out to our own internal individuals, APNs and PAs, also physicians, based on the learning needs assessment, and we would offer 30-minute lunch and learns and offer continuing medical or continuing education. And now we're going to offer Category 1 CMEs. So that's what we kind of did the last year. For our fellows, we also have journal clubs through the partnership with COPE. We have journal clubs. We also started a book club. I have to say that hasn't been as well attended. That's more on a leadership topic. But we're also this year, through our Department of Medicine, we're going to start offering CMEs for our educational events. And we're actually planning a half-day conference in November for our own APN and PAs to present on hot topics in their specialty, and we're going to offer a continuing medical education. So we're working on trying to build that up in our organization.
That's a lot. And Beverly, I think you've been with the organization for 1.5 years now, 2 years?
2 years. 2 years.
So 2 years. So she's done quite a lot there. It's pretty impressive. She's got a lot of,
well, it's not just me, but
great advice.
Thank you. Not just me.
It's a great team, but
yes,
you spearheading a lot of this, has done some great stuff at that organization. And I think this is why you're starting to see more and more APPs want to apply to work for this organization, which is great to see. Helen, let me ask you a question that was submitted via the email. I think this is a good one for you. What has the physician response been in relation to utilizing more APPs or to bringing on this fellowship? How have your physicians? You guys have one of the largest physician-owned primary care practices in the U.S. What has the response been?
Varied will be my first one to say. And a lot of those misconceptions and assumptions initially and the barriers, but I actually appreciate when people will go ahead and say what their concerns are so that we can spearhead it at the beginning. A lot of financial questions, right? Because we are a physician-owned group, so understanding how it works financially, how does that benefit both life, but also financially. So there's a lot of those questions, but we quickly are able to move into the space of value-based care because that's constantly being discussed with our physicians, and we're able to talk about it in that broader sense. But I really, really believe that one of the best ways we've been able to have a good response from our physicians is to hear from other physicians within our group. So our first cohort has been wildly successful with those practices, and they are serving word of mouth. And then they're also like, I'll get in front of anybody and talk to you about it. And in addition, as a leadership team, we've really tried to I have a great senior medical director who's very, very pro APP development, and we try to go together as a team to be able to talk about all the things and get them out there, but also help dispel a lot of the rumors, if you will. So that has
Yeah.
been one of my greatest ways to show collaboration and to show the benefit in that team
And I'm going to
capacity.
just add a little bit to what I saw Helen do here. She went out with this medical director. She even took us out some of the times too, to these clinics to talk to the physicians one-on-one, to just get a couple to initially agree to take on fellows, to be a part of this fellowship. She had her leadership's buy-in, but she didn't have the individuals in the front level, which, to be honest, Beverly, is exactly what you had to do at your organization as well. But once they got these couple of physicians, there was great success in the program and the fellows. And so, I think it was 3 or 4 months in that those two physicians were saying, hey, let's go ahead and offer contracts. Let's get these APP fellows in for full time, even though they had a 12-month program. And one of them said, let me go talk to any other physician that's not sure about utilizing an APP or the fellowship. And so I think too, the way Beverly and Helen both approached, this is they started the fellowship with a smaller cohort and just built the name and, kind of the consistency, and had lots of one-on-one conversations with physicians and APPs. There was some buy-in that was needed from the APPs about this program too, and being preceptors, and how to compensate the preceptors to be really engaged with us. We have a few more questions. Let's do this last one here. How do we recruit APPs from school to go into primary care as opposed to surgical subspecialties and medical subspecialties and the current state of medicine? That's a good question.
Part of it in the role, if you look at the two professional disciplines, the advanced practice nurse, they typically, their primary training is either primary care, family medicine, women's and children's pediatrics, and the initial track of the training is really conducive to the primary care model, and also to the physician assistant, although they can go into specialty models. But a lot of it too is individual preference. I mean, let's be honest. I mean, there are some people that even when we interview them, we are very clear when we interview them. We say, this is a primary care fellowship. You will go to specialty rotations, but because you spend 6 or 8 days in cardiology does not mean when you finish the 12-month fellowship that you will then be able to go in to be a cardiac, advanced practice provider. So we're very clear. And there are people that tell us right in the beginning, listen, I've always wanted to be in dermatology. And we're honest with them. We say to them, then this really isn't the fellowship for you. And that's the reality of it. You try to be as open and honest as you can. We do bring APN and PA students to our organization. So we do recruit, and I know our co-partners are have such a reach of academic institutions across the United States that they also assist in the recruiting and the marketing for the programs as well. But part of it is individual preference, but it's also being honest in the interview process as well.
I'll back that up. I'll just say that I think that was one of the huge things for me once we got COPE on board, was they were able to get into so many different places, social media, marketing, all the different things, that it really helped open up that possibility for us. We had a lot more applications for some spots, which then helps me to be able to say to our physicians, hey, we've got some options here, and we can really make sure that people are serious about primary care. Also getting into the schools, we've formed some relationships with several of the schools around here, and getting in early and saying, hey, if you think you're interested at all in primary care, it kind of answers one of the questions about school rotations too. That's a way to try to start getting people interested, offering some hours to those people who might actually be interested in primary care, and utilizing that as beginning that relationship.
Yeah, I think those are great points. And I think, to Beverly's first point, there's going to be people that just want dermatology. Like, we're not going to sway them. And if we do, maybe we get them for 6 months and then they go back. But I do think with NPs and PAs, they are trained to go into any area. And so when you look at a lot of them, when they graduate, some may be strained towards a more specialty area because of the training or the overwhelmed feeling of primary care. I mean, most of us were thrown into a primary care practice with, 2 to 3 days onboarding. And then it was, here you go. Here's 20 to 30 patients to see a day. And, I would 10 times rather go into a niche or very subspecialty where it was going to be a little bit more concentrated, a little less overwhelming for me as a new provider, than to go into primary care and feel completely overwhelmed. And I think when you build in these residencies and fellowship and education for the new providers, you will see those that wanted to potentially be in primary care going into primary care because they're not scared that they're going to be, put into the sharks to sink or swim, or, you figure this out in 3 or 4 days, as opposed to sometimes what you can get in the really more niche or specialty areas. I think that will really help with our recruitment into primary care too. We are about out of time. I know I did not answer all the questions that were submitted, but what I will do is our team will take a look at all of those questions and we'll send it amongst the panelists so they can add anything to it. And we'll make that available for all of you that were on this webinar to share. I want to thank my 2 colleagues who have also been my 2 partners the last couple years in these fellowships, and absolutely wonderful to work with, and 2 incredibly very smart leaders, Helen and Beverly, for being panelists today and sharing some of your words of wisdom with everyone. Really helpful. And if you guys have more questions for them, let us know. We promise, Beverly and Helen, we won't overwhelm you, but we might be able to get a couple more over to you. I think, someone just put up a applause, but really do applaud these 2 ladies. What they have done at their organizations is nothing short of remarkable, and what they're doing for the future of healthcare, I think, is incredibly inspiring, and just really awesome to see what this is going to look like. So thank you both, Helen and Beverly.
Thank you. I also want to thank you, Elizabeth. For you and the team. I know Gabby's here as well, and everyone. Just really can't thank you enough for all the support that you've given along the way and continue to do that. So, we wouldn't be here if it wasn't for you as well. So kudos and thank you for all the work that you do in transforming the transition to practice for advanced practice providers.
Thank you. I appreciate
Couldn't
that.
agree more. Thank you, guys.
Thanks, guys. Have a good day, everyone. Thank you for joining.
Take care.
Bye-bye.
Bye.